Welcome to your very last lecture for Pathophysiology. You should have read these 3 chapters by now. Let's get started. This week is our last week together, and we'll look at the pathophysiology of the nervous system, including the central nervous system, which consists of the brain and spinal cord, along with the peripheral nervous system. The central nervous system receives and processes the information gathered from the peripheral nervous system, and it is essential for our bodies to function and move. First, we'll look at stroke, then trauma of the brain, diseases of the brain and spinal cord, and then end with trauma of the spinal cord. The brain is truly a vital organ, as it is essential to who we are. Without the brain, you are not you, and your body will lose most of its functions. There are still a lot of unknown about the brain, but we do know a good deal on how it functions and which parts do what for us. Let's review what you learned about in AP2 about the brain, spinal cord, and cranial nerves. The brain is made up of 86 billion neurons, which receive information through their dendrites, then send a signal from their cell bodies down axons and electrical current to the synapse, where a chemical messenger is released via the synaptic cleft to its target, which is in this case another neuron. These neurons are supported by even more cells called neuroglia. Neurons transfer information via an action potential generated by the cell body that goes down the axon. This is amplified by the myelin sheath in the areas where there is not myelin, or the gaps through saltatory conduction. The neuroglia help maintain the myelin sheath in the central nervous system. We will see disorders that cause degradation of the myelin sheath, and this interferes in the strength of the conduction. After the axon, the signal goes from the electrical to a chemical signal. The neurotransmitter is released at the synaptic cleft and interacts with another neuron if it is in the brain, or a muscle or gland if this is the peripheral nervous system. Acetylcholine is the main neurotransmitter involved in muscle and can be excitatory or inhibitory. Serotonin is a neurotransmitter that increases our sense of well-being and is involved in depression when it's low or absent. Dopamine helps with movement and memory, and if it is low or inhibited, it can result in Tourette syndrome or Parkinson's disease. GABA or GABA, norepinephrine, and glutamate are other important neurotransmitters that you learned about in Anatomy Physiology 2. Time now to review the brain anatomy. The cerebrum is the largest portion and has 2 hemispheres, left and right. The thalamus is inferior to the cerebrum, and the hypothalamus is inferior to the thalamus, hence its name, as hypo is the prefix for below. Next to the pituitary gland and inferior to this is the brainstem, consisting of the pons and medulla oblongata. The cerebellum, or little brain, is just posterior to the brainstem and inferior to the cerebrum. The spinal cord is the most inferior, pictured here, starting just below the brainstem. We can isolate various functions of the brain based upon the hemispheres and the lobe where it occurs. Note the brainstem aids in respiratory and heart rate control, and the cerebrum helps in balance and coordination. The medulla oblongata is known as the vital signs center, as it aids in heart rate and respiratory rate both. Here are the lobes of the brain. Frontal, which is most anterior, then temporal lobes, found most laterally on each side. The parietal lobes, found most superior and bilateral. Lastly, the occipital lobe, which is most posterior. Notice Broca's area, and if this is damaged, it can result in expressive aphasia, and Wernicke's area, if damage, can cause a receptive aphasia. Aphasia is difficulty in speaking or understanding language. Now let's understand what each lobe does primarily. The occipital lobe helps us understand what we see and interpret those images. The temporal lobes help us hear and understand what we have heard. It also aids in language comprehension and is most important with memory. The parietal lobes help us with movement and sensations like pain, touch, and temperature. It also provides us a sense of proprioception, or the awareness of where your body parts are located. The frontal lobe is your personality, intelligence, and higher level of executive thinking. It is also involved in emotions and expressions of speech. It has been shown to be related to judgment, reasoning, and aggressive behaviors. For the exam, you need to know what each lobe does in the brain and which side of the brain is responsible for speech normally. The peripheral nervous system consists of all the nerves that come off the spine as well as the cranial nerves. They send signals to our muscles and glands and receive information back from our sensory receptors. Some of these nerves control voluntary movement like our motor neurons, and others stimulate our inhibitory or involuntary functions like digestion or heartbeat. The voluntary portion is called the somatic nervous system, while the involuntary is called the autonomic nervous system. The autonomic nervous system consists of the sympathetic nervous system and the parasympathetic nervous system. The sympathetic nervous system helps in fight or flight situations like a bear chasing you. The parasympathetic nervous system is in times of calm, like digestion. The spinal cord ends at the cauda equina, which means horse's tail. Now let's look at the cranial nerves in more detail. Cranial nerve 1 is the olfactory nerve, and this is for our sense of smell. Cranial nerve 2 is the optic nerve, and this enables us to see the world around us. 3 cranial nerves together, 3, 4, and 6, which are the oculomotor, trochlear, and abducens nerves respectively, all help us with movement of the eye. The trigeminal nerve, which is cranial nerve 5, is used for facial sensation, whether bad or good. Cranial nerve 7 is the facial nerve, and this allows for facial movement and expression. Nice kitty. The vestibulocochlear nerve, which is cranial nerve 8, not only gives us the ability to hear, but also helps us with equilibrium or balance. Taste comes from cranial nerves 7, 9, and 10, or the facial, glossopharyngeal, and vagus nerves respectively. The vagus nerve also gives us autonomic control of such involuntary movements like our heartbeat and digestion. Cranial nerve 11, or the accessory nerve, innervates the trapezius muscles that allow us to shrug our shoulders like when you don't know the answer to a question on the next exam. Lastly, cranial nerve 12 is the hypoglossal nerve, and this allows for movement of the tongue. You must know the functions of the cranial nerves for the examination. Recall the spinal tracts and how they cross over at varying points. This is why when we study strokes, that the symptoms will appear on the opposite side of the body of the stroke. For example, a right hemispheric stroke will affect the left side of the patient's body. When assessing a patient, you must check their muscle strength versus their reflexes. The reflexes are communication directly with the spinal cord, while many other functions like muscle sensation, coordination, proprioception are higher level or upper motor neuron. Strength tests both upper and lower motor neurons, as you must hear the command to move the arm or leg, etc. Then respond with the appropriate resistance. If the nerve loses contact with the muscle, then it will not contract and the muscle will atrophy. If the spinal cord at that level is cut off from the brain higher up, then again the movement will not happen. A Babinski reflex is a special reflex which only is positive in individuals with an upper motor neuron lesion. It is usually in patients with brain damage or spinal damage. It is a normal reflex, though, of children and babies less than 2 years of age. Recall the circle of Willis and the arteries that supply the brain and spinal cord. The MCA, or middle cerebral artery, is the most involved in strokes, as it is the main artery for the lateral cortex. The circle of Willis is a site of aneurysm formation in hemorrhagic strokes. A stroke, or CVA, which stands for cerebral vascular accidents, is where the blood supply is cut off from an area of the brain. There are 2 types, ischemic and hemorrhagic. You can also have the mini stroke, as they are called, which in fact is a small stroke that reperfuses and is known as a transient ischemic attack, or TIA. Remember, ischemia is not infarction, and if the blood flow returns, then there is no tissue damage. The most common type of stroke is ischemic stroke, which is also known as a thrombotic or embolic, depending on the source of the blood clot. If thrombotic, then it forms at the same site, but if embolic, then it came from another area and migrated. Blood supply is cut off to the brain for a time, but as long as the perfusion can be restored in a timely manner, then the brain area can be saved. If the blood clot persists and the blood flow is not restored on time, then the area of the brain will die. In the past, these were also known as brain attacks, just like we use the term heart attack to describe infarction of the heart. Here's another visualization of ischemic strokes from your textbook images. The source of the clot can be local or thrombotic, but many times it travels from the atria if there is atrial fibrillation, or from the carotid arteries if there is significant carotid stenosis. This is called an embolic stroke. Ischemia will lead to infarction if the brain is not reperfused in time. Another type of stroke is hemorrhagic stroke. It occurs when a brain blood vessel ruptures. This usually occurs due to an aneurysm or severe arterial atherosclerosis causes a weakened arterial wall. The blood vessel bleeding causes two key issues. First, the loss of blood reduces the amount of oxygen to the area the blood vessel normally supplies. Second, the blood creates pressure and edema to the brain, crushing the area near the bleeding. If too much intracranial pressure, then the brainstem will herniate through the foramen magnum, which causes brain death. If compression occurs for too long without herniation, then this can cause anoxic brain injury as the area grows. Treatment for this would be removal of the bleeding area to lower the pressure, then the restoration of blood flow to that area of the brain if possible. Risk factors for stroke include hypertension, hyperlipidemia, diabetes, smoking, obesity, atrial fibrillation, estrogen use, alcohol use, family history, and age greater than 55. Males are higher risk than females. African Americans have a higher risk than Caucasians or other ethnic groups. Sickle cell disease, recent TIAs, and amyloid plaque accumulation like we see in Alzheimer's dementia. The sign of a stroke may be vague but can begin with a terrible headache, sudden loss of speaking ability, or sudden numbness and tingling on one side of the body or face. Loss of vision could be a sign as well. As slurred speech, drooling, dizziness, and confusion, it is important to recognize the symptoms of a stroke as minutes cost brain tissue, just like an MI, where it is a race against the clock to save heart muscle. If the patient has a headache, ask them if this is the worst headache they've ever had in their life, or they've never had a headache before, and now this is the first one they've ever had. If they answer yes to these questions, then it could be a hemorrhagic stroke like a subarachnoid hemorrhage. Subarachnoid hemorrhage occurs mostly as a hemorrhagic stroke, as we have discussed, resulting from ruptured brain aneurysms, with the Barre aneurysm as the most common. It can occur due to brain trauma as well. See the subarachnoid hemorrhage in the CT scan? Look at the abnormal amount of white material on the patient's left side. Remember, in a CT scan, the patient's lying with their feet in front of you and supine on a table. The left side of the screen is the patient's right side and vice versa. Another way you can tell that there is a hemorrhage on the left side of the patient's brain is the asymmetry of the ventricles, with the ventricles looking like they are moving toward the patient's right or toward the left side of your screen. This is why we have to do a CT scan as soon as possible on a suspected stroke patient to look for any signs of brain bleeding, as this would be a contraindication for TPA. Again, here are the signs of stroke. The American Stroke Association, which is part of the American Heart Association, simplifies this for the public with the mnemonic FAST, which stands for face drooping, arm weakness, speech difficulty, and time to call 911. Once they arrive at the ER, and even when they are assessed by the EMS, a thorough neurological examination must be performed. Check their speech, how they respond to questions. Is there a facial droop on one side? Check their muscle strength, coordination. What is the light reflex? Use the NIH stroke scale to aid you in your assessment and rate each factor. Once your assessment shows a potential stroke, then get a CT scan of their head as quickly as possible to rule out a brain bleed. This is time sensitive as we consider the patient for TPA. You can assess the total score on an NIH scale using this key. For example, say the patient had a score of 30, then this would be considered a severe stroke or a very severe stroke. For the exam, pay attention to the three areas with the red boxes and the total key. TPA, or tissue plasminogen activator, can be used IV to dissolve blood clots. If you're having trouble with a thrombotic stroke and know the time of onset and there's no evidence of hemorrhagic conversion, then by using TPA IV, you can save the patient from permanent infarction and reperfuse the area before it has infarction and while it's still in the ischemic stage. Same for myocardial infarction or a pulmonary embolism. There are contraindications to TPA, however, as it can increase bleeding risk. TPA can be adverse for the patient if you are dealing with a hemorrhagic stroke, for example, or don't know the onset of the stroke. Also, if they had recent head trauma, or this can increase bleeding risk in the brain. Recent GI bleeding is also an exclusion, as this will only make the patient worse. Are their stroke symptoms getting better quickly? This too could be a reason not to use TPA. Another reason not to use TPA is if it is unknown when the stroke symptoms started. We only have 0 to 3 hours for most patients, with a maximum of 4.5 hours if using intra-arterial TPA. TIAs or transient ischemic attacks resolve their symptoms quickly and are contraindicated when considering TPA. They can be warning signs of stroke, however, and warrant a thorough stroke prevention workup. Leucuna Anaphorics are tiny strokes. They can be due to uncontrolled hypertension or could be the sign of endocarditis. They are so small the patients usually have few to no symptoms and are usually discovered when the patient gets a CT to the head or an MRI of the brain for some other reason. Once the CT scan is shown to not have a brain bleed and the patient is considered to get TPA and not based on their symptom evolution, and if they have or do not have any of the contraindications, then we proceed with an MRI scan of the brain. Many ischemic strokes will not show up on a CT scan right away, but will show up sooner on an MRI of the brain, and MRI is the best image of the brain we can get. This MRI of the brain turns out to have what may be a right-sided brain mass around the frontal lobe of this patient. An MRA of the brain and carotid arteries can be done to look for blockages and aneurysms. You can evaluate the need of a carotid endarterectomy, or you can find undiagnosed aneurysms. After a stroke, patients must rewire their brains with physical and occupational therapy sessions and may even benefit from intensive rehabilitation before returning home. Now let's go back to brain bleeds, as we have already discussed subarachnoid hemorrhages, which can be idiopathic from a ruptured aneurysm, from uncontrolled hypertension with the worst headache of their life, or could be due to trauma. Remember, each layer of the meninges from AB2, most superficial is the dura mater, then the arachnoid, and deepest is the pia mater. A subarachnoid hemorrhage, therefore, is below the arachnoid layers, as sub means low, and arachnoid, of course, refers to this layer of the meninges. What about an epidural hematoma or hemorrhage? Epi is the prefix for above, and dura refers to the dura mater, so this bleed is above the dura mater. What about subdural hematoma? Again, sub is a prefix meaning below, and dura refers to the dura mater, which means the bleed is just below the dura mater layer of the meninges. Here's a CT scan with an epidural hematoma. This is a common brain bleed from head trauma. This is usually associated with a skull fracture. Head bleeds like this will increase intracranial pressure and can cause a loss of consciousness. Evacuation of this blood will decrease the pressure and edema on the brain. Here's a CT scan with a subdural hematoma. Look at the bright white area of this patient's left side, which for us is the right side of the screen. Blood is white on a CT scan as it uses X-rays, which are reflected best by calcium. Bone contains the most calcium, so it shows up as white on X-ray. Blood also contains calcium, so it will show up as white. You can see the large area of the blood in the subdural space on the patient's left side compressing the brain. It is pushing the brain towards the patient's right side or the left side of our screen. Remember, in a CT cross-section, the patient is laying on their back, which is called supine, and the soles of the feet are facing you. So the right side of the screen is the patient's left and vice versa. Subdural hematomas are the most common type of traumatic hematoma and can be acute and bleed quickly, or subacute and bleed much slower. This can present as severe head trauma, and the patient is awake denies any problems right away, but later begins to lose consciousness. This is due to potentially slow bleed of this type of head trauma. Again, here's a difference between an epidural hematoma and a subdural hematoma. Look at the position of the dura mater. In a subdural hematoma, the dura is attached to the skull, while in the epidural hematoma, the dura is against the brain and then detached due to a skull fracture. Skull fractures, again, can cause epidural hematomas, particularly depressed type skull fractures, which are the most common due to this. Here's a CT scan of the skull reconstruction of a patient with a depressed skull fracture. Notice the displacement of the bones. Linear is the most common type of skull fracture and the least damaging of the skull fractures. It does not affect the brain tissue. The last type of skull fracture is the basilar. Basilar skull fractures involve the temporal bone, and damage to the mastoid process is common. This can cause CSF leakage and bruising around the eyes, resulting in raccoon eyes, you see here in this illustration. This is also called periorbital ecchymosis. Here's another CT rendering, this time showing a mandibular fracture. See the fracture in the center of the mandible? Diagnosis of skull fractures is by X-ray and likely CT scan also. CT scan sees bone better than MRI and are useful in skull fractures for this purpose. If you have a rhinorrhea that is persistent following a skull fracture, this may be CSF, and otorrhea or discharge from the ears, most definitely CSF following a skull fracture. This patient should be monitored for bleeding and level of consciousness. Surgical evacuation of the bleed may be necessary to reduce intracranial pressure. So we have mentioned to you the dangers of increased intracranial pressure. Remember, we talked about a lumbar puncture way back in week 2 when we were looking at meningitis. CSF is clear and is located below the arachnoid mater, the meninges, in the subarachnoid space, and surrounds the brain, is located in the ventricles of the brain as well as down the spinal cord. CSF is a major contributor to intracranial pressure. As we said before, CSF is a major contributor to the intracranial pressure along with the brain tissue and blood flow. This can be affected by a massive brain bleed or even a large growing mass in the brain causing increased intracranial pressure. An open fracture in the skull can cause decreased intracranial pressure. If the intracranial pressure changes cannot compensate, then the brain may herniate out of the skull space through the foramen magnum, where other brain damage may also occur. Signs of increased intracranial pressure can include decreased level of consciousness, dilation of pupils, headache, papilledema, which is when the retina looks edematous on an ophthalmological examination. Hypertension can also be a sign, along with wide pulse pressures, bradycardia, and an abnormal respiratory pattern. I once had a patient I was consulted on for ventilator management by cardiology who came from another hospital to get a balloon pump inserted due to a severe heart failure from a cardiac arrest. When I came to see the patient, they were on the ventilator, of course. When I did my neurological exam, the patient had pupils the size of pie pans and very dilated. Ordered a stat CT scan, and they had a huge brain hemorrhage. This is why critically ill patients must be neurologically assessed, as the cause of cardiac arrest may be due to a head trauma and not the heart. As intracranial pressure builds, say from a brain bleed, the risk of decompensation increases to the point that the cerebellum will herniate through the foramen magnum. This is known as cerebellar tonsillar herniation. This will cause sudden death as it will damage the breathing and respiratory centers of the brain located in the brainstem. Traumatic brain injury is the most common in males, more common in males than females, more common in younger than older people. The result may be just a concussion or at worst, significant brain damage. The injury can be a blunt force hit to the skull, causing the brain to hit the opposite side, or from an accelerated, say in a motor vehicle accident where a car stops suddenly as it hits another car or object and causes the brain to move in the skull, stretching out neurons. Assessing a patient with traumatic brain injury begins with assessing their level of consciousness, or LOC. Are they awake? Are they speaking? Make sure they have a pulse and breathing. If this is intact, then at least the medulla oblongata is intact. Are the pupils reactive? Do they open their eyes? Assess if they have only an upper brain issue, or is this a lower brain problem? Remember from our review that the higher levels of the brain, like the cerebrum, are in charge of higher levels of thinking, and the midbrain and brainstem are in charge of more basic functions, and the cerebellum is in charge of coordination. You can assess a patient with a good neurological examination. The Glasgow Coma Scale can be a quick and efficient way of assessing the patient's level of consciousness. For example, a patient who has no motor response gets only one motor point, no verbal response, then another point under verbal response. And lastly, no eye opening under eye opening would give the patient a total of 3 points, which would be severe brain injury. A neurological examination should be performed on a patient to assess any damage. Checking the visual field, sensation, reflexes, and muscle strength. Any abnormalities may be a sign of brain injury. Concussions are the most common type of traumatic brain injury and are classified as mild. The patients are usually are conscious and have a high score on the GCS. They may have little to no symptoms. They could have lost consciousness for a short time or saw stars after being hit. They may have memory issues, headache, or other temporary neurological manifestations. The more concussions a person has, the worse symptoms will get as they have an accumulative effect over time. Concussion should be monitored, and the person must abstain from physical exertion for a time period. Many in contact sports may suffer from concussions, and they must have a rest period following injury to avoid further brain damage. If many concussions, then they may need to stop the sport entirely. Coma occurs with severe TBI, which is diffuse axonal injury or DAI. Coma is the loss of consciousness for a long period of time following a total a brain injury. Brain swelling occurs, and the patient is highly likely to have significant brain damage even if they awaken. Epilepsy is a common neurological disorder that can come from head injuries or traumas as the most common cause. They're also hereditary in nature. Sudden discharge of neurons from the brain resulting in tonic-clonic movement is the most common presentation. Remember, seizures are the symptoms of epilepsy, and epilepsy is the neurological condition. The patient may lose consciousness or control of their limbs or whole body. Depending on the symptoms, this will classify the type of seizure. Most seizures begin with an aura or prodrome of some type. This will then be followed by the symptoms. There are 3 categories of seizures based on what is seen on EEG. Clonic, atonic, myoclonus, and absence, which are non-motor, can be observed. Again, the patient will usually have an aura or pre-symptom following this by the seizure symptoms. Ictal is the time of the seizure, and postictal is after the seizure. The postictal stage is usually memory loss and confusion. Epilepsy comes from head trauma, genetics, just getting older, brain diseases, malformations. It causes continuous stimulation of neurons in the brain. Hypoglycemia, hyponatremia, respiratory alkalosis can cause seizures due to metabolic instability. Alcohol withdrawal seizures are very common in alcoholics. Evaluation with CBC and chemistry to look for metabolic causes, followed by brain imaging with CT and indoor MRI. EEG or electroencephalogram, as you can see here, will study the electrical signals of the brain to find the focus of the seizure and better understand what provokes them. The patients are subjected to flashing lights and sleep deprivation, which many times will provoke seizure in many epileptics. Treatment is the anti-epileptic drugs, which help to slow down the fast activity of the brain. Related to an EEG is the polysomnography. This is done in a sleep study. We use sleep studies for evaluation of sleep apnea, like we discussed back in week 5. But it's also used in evaluation of narcolepsy, insomnia, sleepwalking, and other sleep disorders. Tension headache is the most common type of headache. It is caused by muscle spasms in the head and does not have any other accompanying symptoms like nausea or photophobia. Many describe it as having a vice grip or clamp tightening on the head, as the pain usually is around the head and temple areas and is bilateral. Migraine headaches are the next most common type and are quote unquote sick headaches, which means there are many associated or accompanying symptoms. It is usually unilateral and is preceded by a prodrome or aura, much like a seizure. In fact, migraine is considered a cousin to seizures as they have several similarities. Photophobia or sensitivity to light, phonophobia or sensitivity to noise, along with nausea, vomiting, dizziness, and visual loss can all be symptoms. Many times the aura is a ring of visual disturbance and can make the person temporarily blind if it covers the visual field. Some migraineurs will only have the aura and not the headache, but all with the headache will have some aura. Migraines are triggered by certain foods, low blood glucose, excessive exercise or stress, lack of sleep, bright lights, etc. It is caused by vasodilation of the blood vessels or the meninges, blood vessels of the meninges. It is treated by vasoconstrictors like sumatriptan or Imitrex. Cluster headache is rare. It's a rare type of headache. It's usually in men and unilateral and often involves an eye. It's due to trigeminal nerve irritation and also causes tearing, bloodshot eye, or both eyes, rhinorrhea, pupil constriction, and eyelid edema. This is also a vasodilation mechanism like migraine and can mimic migraine headache. Parkinson's disease is the lack of a significantly decreased amount of dopamine, which results in a resting tremor. This tremor or rigidity is due to unanswered acetylcholine in from the muscle motor neurons. The dopamine is depleted due to deterioration of the substantia nigra of the brain. These patients will have unilateral symptoms at first, then evolve to bilateral resting tremor. This means when they use their muscles, they do not have tremor, but at rest, they have tremor. They usually have stoic or expressionless faces. They have a shuffling gait and will bend forward to watch their feet as they walk. As you can see here in this image, to the bottom right of your screen, the substantia nigra of the midbrain of the Parkinson's patient is much lighter, as it has degraded, than that of a normal patient midbrain. An examination of a Parkinson's patient will show a resting tremor with observation. This is important as an intention tremor is a completely different and much more benign disease. On active movement, there will be little abnormalities, but with passive motion testing, you will observe cogwheel rigidity. Observe the gait, and it may be somewhat normal at first, but in more advanced disease, they cannot pick up their feet as well when they walk and will shuffle as they move. And this will cause them to walk more carefully and watch their feet as they not trip over anything in their path. Treatment is to replace the dopamine they are missing, and this works for a time until greater and greater amounts are needed for the same effect. A pacemaker placed in the brain has also had some good results. The disease will progress, however, and lead to death. This disease should not be confused with Parkinsonism. It is a much milder version and does not progress as rapidly and have as severe symptoms. What is cogwheel rigidity? This is a frequently asked question by students once they read about this term when it comes to Parkinson's disease. Just the cogwheel of a large machine, just imagine that seen here in this simulation image. The wheels spin in opposite directions and meet each other with the teeth of their gears. One wheel is powered and turns the other, which is not. And both then spin in opposite directions but perform the same task. When testing the passive motion of the patient with the Parkinson's disease, they cannot truly relax. So the practitioner can move their limb or what have you, and they resist without meaning to. Here in this picture, the practitioner is attempting to flex and extend the patient's wrist, but is meeting resistance in the opposite direction. This rigidity that the Parkinson patients have is the cause of the tremors and due to the lack of the adequate supply of dopamine. Alzheimer's dementia is the leading cause of dementia. Dementia is the loss of cognitive ability with short-term and then long-term memory loss. There are other types of dementias like normal pressure hydrocephalus and Lewy body dementia. There is no cure for this disease, but some treatments have slowed down its progress. Amyotrophic lateral sclerosis, aka ALS, or Lou Gehrig's disease, named after famous baseball player Lou Gehrig, is a neurodegenerative disease where both upper and lower motor neuron ability is lost. It causes painless muscle weakness and atrophy. Sensory and cognitive ability remain intact, though. Famous physicist Stephen Hawking also had this disease. It ends with respiratory failure with need of a ventilator with support. Progressive muscle weakness, atrophy, dysphagia, spasticity, positive Babinski Reflex are all physical exam findings. No lab data is helpful, and there is no cure. Multiple sclerosis, or MS, as it is known, is a demyelinating disease. We mentioned the importance of the myelin sheath at the beginning of this lecture in our AP review. It again is important in maintaining and amplifying the electrical signal that traverses the axon of the neuron to reach the synaptic cleft. MS causes an autoimmune attack on the myelin sheath, resulting in axons that have partial or damaged myelin sheaths. This results in weakness, numbness, balance problems, dysphagia, hemiparesis, paraparesis, memory, and cognitive issues as well. Diagnosis is by MRI scan, which shows diagnostic lesions in the brain's cortex. CSF analysis is also done, and it is important to rule out syphilis as it can cause similar issues in later stages. Treatment is by immunomodulating agents like we used in RA and lupus and other autoimmune diseases. This gives credence to the autoimmune theory of MS's origin. Nystagmus is involuntary eye movements, and there are different types. This can be from benign problems to severe neurodegenerative diseases like MS. It is detected best by electronystagmography. Huntington's disease, as we discussed in the very first lecture of this course, is autosomal dominant. And those who get it usually know they're going to have it, as other family members have it already. As we can see here, the frontal horns of the lateral ventricles are much larger in the patients with Huntington's disease. Huntington's disease, or Huntington's chorea, is an autosomal dominant disease that comes about in midlife. There is no cure, and the patients know they will have it one day as other family members have it as well. Some get tested for the genetic defect so they know they will have it or not, but others elect not to get a test done. The disease causes a dance-like movement disorder known as a chorea. Athetosis is the twisting and writhing movements these patients undergo. Dyskinesia is a generic term for a movement disorder. Imagine having a virus or urinary tract infection and ending up on a ventilator as you cannot move. This is Guillain-Barre Syndrome. It can happen to anyone untreated for bacterial infections such as enteritis bacteria we studied, to complex UTI bacteria along with some viral infections, can cause a distal numbness and tingling to the limbs that moves more proximally. Eventually, difficulty moving muscles begins and can worsen to the point you cannot breathe on your own. This is a result from another autoimmune demyelinization, but it is only temporary and usually will reverse given time and support. Myasthenia gravis is a muscle weakness due to an autoimmune attack on acetylcholine receptors. Remember from our review that acetylcholine is the neurotransmitter used by motor neurons as their synaptic clefts to communicate with muscles they are innervating. There are two types, ocular and general, and treatment involves increasing acetylcholine and removing the thymus, as the autoimmune response is likely due to changes in the thymus gland, as many with this disease have a much larger thymus than they should normally at their age. Now let's look at the spinal cord in strokes. The spinal cord can be injured just like the brain with traumatic events. It can also experience strokes, either ischemic, which is also called thrombotic, or hemorrhagic, and that just depends on the situation. Remember, the information from the brain travels down the spinal cord through the tracts, so we so loved learning in AP2. If an injury occurs higher in the spinal cord, say in the cervical spine, then the damage is much more extensive, as it will affect the innervation of everything below. If the damage occurs lower in the spinal cord, say the lumbar, area, then the damage is not as severe, but there still will be detriments. Quadriplegia is loss of movement and sensation in all four appendages and usually involves lesion or damage in the cervical spine area, while paraplegia is just the legs and involves damage in the thoracic or lumbar spine. Sensation is lost as the ascending tracts are interrupted and movement is lost due to damage of the descending tracts. This is termed paralysis if movement and sensation are both lost. There are some crossing over, so the damage is not complete, and there may be some instances of sensation and or movement still present. Remember the dermatomes? Each spinal nerve innervates a particular area of the body, and because the information from the brain goes down the spinal cord, these nerves will be cut off below the insult to the spinal cord. An example of a paraplegic patient who only had lost leg movement and sensation, but can move their arms, and this likely is a lesion at the thoracic or lumbar spine. If we can see that they can sit up in the wheelchair with little effort and without any belts or support, then the damage must be lower and in the lumbar spine, as the muscles that aid us in sitting up without falling are mostly in the thoracic spine and the upper lumbar area. If a patient is a quadriplegic, then we can guess that damage is cervical spine, as the arms and hands are affected. Those spinal nerves we showed you earlier innervate areas of the body close to where they are located. Nerves of the cervical spine, for example, innervate areas of the back of the head, neck, diaphragm, along with brachial divisions, which from this area provide innervations with the arms and hands. Thoracic nerves providing innervations of the area of the chest and lungs. Lumbar nerves, which innervate areas of the abdomen and abdominal muscles. Sacral nerves, which innervate muscles of the buttocks, thighs, and legs. So you have a patient who's had a spinal trauma, but no head trauma, and you must assess them. Is the trauma primary, meaning the spinal cord was cut off or severed, or by something else, or secondary, say from a stroke or hemorrhage in the area depriving the spinal cord of blood and causing ischemia and then infarction? Is this lesion at C4 or above, as this will affect the diaphragm and their ability to breathe on their own, and they will need a ventilator, likely for the remainder of their life? Placing a patient in a cervical collar is important, as there could be cervical fractures that could damage the cervical spine further, and this needs to be evaluated prior to removing the cervical collar and moving the head. Maybe they're having shock or hypotension. This could be because of the interruption of T6. This is where the parasympathetic control of the heart rate occurs, and damage to this area may require the patient to be on IV agents to raise their blood pressure. If the patient's in shock, then it could also be due to internal bleeding, since they have just had trauma. So this too needs to be evaluated. If the patient is conscious and talking fine, then assess the sensation to pinprick and then to light touch. This will help you localize the lesion. If they can feel sensation, can they feel pain? Can the patient tell this is a sharp object or a dull one? Can they tell the difference if they have 2 points touching or just one? Assess their movement as well. Can they move their limbs to gravity? Can they move against your force, or how strong is this movement? You can grade the ability, patient's movement ability on a scale of 0 to 5. 0 is no movement, all the way to 5, which is normal movement. Where they cannot move will also aid in showing where the spinal cord lesion may be located. Cervical spine innervates our upper extremities, and lumbar our lower extremities. A lesion in the C-spine would affect all 4 limbs, as this information from the brain travels down the spine to command the muscle movements. Damage to the lumbar spine only would still allow the patients to move the upper extremities, but the lower extremities would still remain impaired. The Asia Impairment Scale was developed to help those in the trauma field be able to quickly assess a patient's neurological damage. By testing certain muscle groups for strength and sensation, you can assess where the lesion or damage in the spinal cord may be located. It can also help to clear a patient with suspected spinal cord trauma so braces can be removed. Usually these patients will get full body CT scans pretty quickly if they are in a trauma center, which is also will also aid in spinal cord assessment. Let's talk a minute about this again, as there are a few questions you may get on the exam about paraplegia and quadriplegia. The patient has a motor vehicle accident and damaged their spine at C2. What symptoms will they have? First, they cannot move much at all. Even their head and neck would be mostly immobile. They would not be able to breathe on their own, as this is above C4. They could not sit up on their own, as this is above the T5, T7 area. They would not be able to defecate or urinate on their own, as this is above the sacral nerves. Now, what if the lesion were at T7? Then they would be paraplegic and not quadriplegic, as they can move their arms freely, as this is below C5 to C8. They can sit up on their own, as this is below T1 to T7. They cannot move their legs and do not have control of their bladder or bowels. Do you see how this works? This is how complete damage to the spinal cord works. Now, if it were incomplete, you may see some hemiplegias. Lastly, for quadriplegic patients that are bedbound, the worst possible complication would be a pressure ulcer. And this is why they must be turned frequently, as they cannot do this themselves if the lesion is very high up. Horner syndrome comes about from damage to the carotid artery, which in turn causes spinal stroke or damage to the pathway in the brains that control eye movement and pupil dilation, which is the cervical plexus supplying the sympathetic nervous system. This can occur in children from childbirth trauma. The patient has a ptosis of the eye, miosis of the pupil, and anhidrosis or absence of sweating. Brown-Séquard syndrome is a rare neurological condition characterized by a lesion in the spinal cord which results in weakness or paralysis or hemiplegia on one side of the body and a loss of sensation or hemianesthesia on the opposite side. Remember what I said about the nerves crossing, and this is why we get bilateral symptoms. Called Aquinas Syndrome is a surgical emergency. The patient needs surgical intervention within 48 hours to prevent permanent damage to the spine. This can come about slowly from degenerative disc disease or from a tumor growing, but most commonly this comes from a trauma like a motor vehicle accident. Patients will have bladder and bowel incontinence along with possible saddle paresthesia, which means they lose the feeling in the areas where their skin would touch a saddle if they were riding a horse. Myelograms or myelography are X-ray studies of the spinal canal which help us see the flow of CSF through the spinal cord but cannot show intrinsic spinal cord pathology. CT scans can help us see the vertebrae and if there are fractures present, but are not really that good for seeing the spinal cord. MRI scans are the best for visualizing the spinal cord as the nerves as nervous tissue show up really well on them. Remember, CT and X-ray see calcium best, while MRI sees water molecules best, and neurons have water molecules. This ends your final lecture for pathophysiology. Congratulations on making it this far, and good luck on your future course.